hemolysis. The E and the L, which stands for elevated liver enzymes, and the LP stands for low platelet hemolysis, elevated liver enzymes, and low platelet count. You may have learned about this in your, Dr. Church, you went over it during anemias. But we do see this. These patients can also have other possible findings like CNS and renal dysfunction. Majority of them have hypertension and proteinuria because it is a subtype of preeclampsia, but not all patients. The key to this is early diagnosis. So we're going to talk about it in more detail. There's a guide for you from osmosis with a summary of essentials. So in health, symptoms will vary. Up to 20% will be normotensive. Some may not have hypertension, some may not have proteinuria. Remember that. But majority of them will. These symptoms are usually rapid and progressive. The most common symptom is epigastric or substernal pain. Right upper quadrant pain is probably the most common presenting symptom for HELLP syndrome. They also have nausea and vomiting and painful indigestion after eating. Shoulder pain with deep inhalation, nosebleeds, gingival bleeding, vision changes. So some of the same things you could see in preeclampsia, like the edema, for instance, breath, headaches, things like that, but some additional symptoms as well. Remember, right upper gastric pain or epigastric pain is going to be your most common presenting symptom in HELLP syndrome. These symptoms can be mistaken for gastritis, flu, acute fatty liver, gallbladder disease. Eclampsia. So we talked about the difference between preeclampsia and eclampsia. Eclampsia, new onset of grand mal seizures or coma in a patient with preeclampsia that is not attributable to any other cause. This is a common cause of maternal death. And we see it mostly during labor, 50% during labor, but it can happen before or after delivery. The etiology is not very clear. Some thoughts is that it may be related to placental membranes and physiologic reactions to the fetus, as well as ischemia of the placenta. But again, that's not fully understood. If a patient has chronic eclampsia, this is an obstetric emergency. You need to deliver that baby. So chronic hypertension management, this is hypertension we said that you had before you even got pregnant, or that developed prior to 20 weeks of pregnancy, or after 12 weeks of pregnancy. If it's a new onset, you need to do a preeclampsia workup with EKG to make sure you're not missing preeclampsia. If it's old, you need to review their hypertension medications and make sure there are no heterogenic medications. ACEs and ARBs are a big no-no. No ACEs and ARBs in pregnancy. You need to switch their medication. Methyldopa. In one text said it's the drug of choice. The American College of Obstetrics and Gynecology said labetalol and amphetamine are also good choices. So we remember those from the hypertension treatment from preeclampsia. So just remember methyldopa is a safe antihypertensive medication as well. Antidiuretics, they are second line treatment in hypertension. That serial ultrasound to assess fetal growth development abnormalities. Pregnancies complicated by chronic hypertension, regardless of the cause, are at an increased risk for poor fetal growth. I'm going to check that fetal growth every few weeks. So when we're talking about in the antepartum care, we're doing every 4-week visit. You may do an ultrasound like that as well. All right, we're not gonna spend a lot of time here because Dr. Hendricks did go over some of this. I was sitting in on the class, so I know that you've seen some of this before. We have pre-gestational diabetes and we have gestational diabetes. So pre-gestational diabetes is gonna be your diabetes present before pregnancy. This is type 1 or type 2, and that's 10% of diabetes we see in pregnancy. The more common would be gestational, which is 90% of the types of diabetes, 90% of the diabetes you see in pregnancy. And this is with glucose intolerance with onset or first recognition during pregnancy. Remember that glucose tolerance test we talked about getting during the second trimester. These patients are at increased risk of this diabetes mellitus in the future. Screening is complete around 24 to 28 weeks. Insulin resistance significantly increases at 24 weeks. So would I test with a hemoglobin A1C? Would that be helpful, you think, in this case? If you had a first prenatal visit, would a hemoglobin A1C be helpful? You think? Probably not. If we don't get an increase, if we don't see that insulin resistance increase until 24 weeks, then a hemoglobin A1C is not really gonna tell us much if you're checking at that first prenatal visit. So your screening between 24 to 28 weeks is gonna be very important. We talked about the two-test approach. 1 hour glucose intolerance test where they do 50 grams of that syrupy liquid. An hour later, they test the blood sugar. Anything over 190 is diagnostic. Anything between 140 and below 190 needs a second test, and that's that 3-hour glucose test we talked about. These patients are fasting for 8 hours. They come in, drink 100 grams of the glucose. They're fasting for 8 hours, the blood sugar is drawn, then they drink 100 grams of the syrupy glucose, and then they're tested at 1, 2, and 3 hours. These are the abnormal numbers, if they're, the normal numbers. No, that's greater than. Fasting greater than 95 is abnormal. At 1 hour, if it's over 180, that's abnormal. At 2 hours, if it's over 155, that's abnormal. And at 3 hours, if it's over 140, it's abnormal. If it's under those numbers, it's normal. If you have 2 abnormals out of the 4, that is gestational diabetes. 2 abnormal values is diagnostic, 2 or more. What are some of the complications in gestational diabetes? Too much amniotic fluid. They're at a risk for preeclampsia. They're more prone to candidiasis and urinary tract infections. Hypoglycemia due to insulin therapy. Those babies can grow pretty big, so they're at a risk for having to have a cesarean section. Ketoacidosis and coma, as well as other complications might be notable in these patients. So let's talk about the big babies. So macrosomia is a common condition in infants of diabetic mothers. When maternal diabetes is poorly controlled. 4,000 to 4,500 grams for a full-term baby is considered to be macrosomia. 4,500 is for our country. It's a more high-income country, so any baby 9 pounds, 15 ounces or more, that's considered macrosomia. These babies are getting excessive nutrients to the fetus, hyperglycemia, hyperinsulinemia, and they're just growing at a rapid pace. They are at an increased risk of traumatic injury during birth because they're big and the pelvis isn't necessarily grown. So trying to get that big baby out of a small pelvic inlet. So they are at more risk for traumatic injury during birth. Another complication are neural tube defects, which we talked about when we were talking about amniotic fluid. And I'm sorry, not amniotic fluid, about alpha-fetoprotein. autoregression syndrome, which is rare. That's the picture on the right. That little girl has absence of sacrum and defects of the portions of the lumbar spine. And you can see some of those patients online. If you look at pictures of adults with this, they just have more of an upper body and their legs are very stunted. Gestational diabetes, moms are at increased risk of intrauterine and youth restriction, which we talked about last week, as well as delayed maturity of organs like underdeveloped lungs. Definitely, we want to control this. We want to screen for it. Again, 24 to 28 weeks, 2 different types of tests. Glucose tolerance test, if that's abnormal, over 190, then we need to do a 3-hour test and confirm if there's gestational diabetes. Management, you can do a glucose tolerance test at the first prenatal visit if the patient is at high risk. Again, insulin resistance doesn't usually increase until 24 weeks. But if the patient is at high risk, you can go ahead and obtain the glucose tolerance test. Diet and exercise are key. We want to help them control their weight. We want to talk to them about their meals, glycemic control. Insulin is our treatment of choice because you can control it better. It doesn't cross the placental barrier either, which is good. There are oral agents like glyburide that you can use, which is a good choice. It also doesn't cross the placental barrier in high numbers. Want to educate, talk to your patients about what hypoglycemia looks like, so they're aware of the signs. Annual fasting glucose screens to try and obtain or maintain body weight. We want to prevent diabetes in the future. Strict glucose control during labor and delivery. So they're probably going to do hourly blood sugars while they're in labor. Thyroid disease. So there are changes in the thyroid during pregnancy. The thyroid gland produces more hormones to support the growth of the baby. Iodine in our diet is essential for producing those thyroid hormones. The body wants more iodine, and it also gets rid of iodine faster when you're pregnant. Ensuring an adequate intake of iodine is very important for pregnant women. Already are aware of hyperthyroidism versus hypothyroidism. Hyperthyroidism during pregnancy is most commonly due to Graves' disease. Same symptoms, eye changes, weight loss, heat intolerance. And then the treatment, which Dr. Hendricks talked about. PTU, remember P is for pregnancy. In the first trimester, we want to treat with PTU. After that, you can get methimazole. We do not do radioactive iodine in pregnancy and breastfeeding. Do not do radioactive iodine in pregnancy and breastfeeding. The most common cause of hypothyroidism in pregnancy is Hashimoto's. This one's a little bit harder because a lot of those symptoms you already have during pregnancy in hypothyroidism. You gain weight, you're tired, you're sleepy. So this one might be a little more difficult to diagnose. Levothyroxine is safe in pregnancy. Other pregnancy complications. We talked about intrauterine growth restriction already, but we'll briefly go over it again. Remember, this is the estimated fetal weight, not birth weight, the estimated fetal weight less than the 10th percentile for fetus gestational age. This is about the fetus not reaching its full growth potential. This is based on ultrasound. This is growth in the uterus. It's different than small for gestational age. Remember, we said we probably will not know about 40% of the cause. 40% are idiopathic. We don't know what their cause is from. But it could be maternal, could be placental, could be fetal causes. The next slide just have that breakdown of the different causes. Some of those are listed there. Remember, there are two types, symmetric and asymmetric. Which is the most common, asymmetric or symmetric? Anybody remember? Asymmetric. Asymmetric is actually the more common of the two. Remember, symmetric, the baby in general is just small. Head and abdomen match. In asymmetric, which happens later in pregnancy, the brain is spared, so the head is usually bigger than the abdomen. The fetus will shunt its blood to the vital organs, like your brain and your heart, but that's at the expense of organs in the abdomen, so the abdomen is smaller, those babies. At 34 weeks, your abdomen circumference should be greater than the head circumference. So for these little ones, their abdomen is much smaller than it should be when you're measuring during ultrasound. What we didn't talk about last time are some of the complications of intrauterine growth restriction. And that is that those babies are prone to meconium aspiration, asphyxia, polycythemia, hypoglycemia, and mental retardation. They're also at a greater risk of having adult conditions like high blood pressure, diabetes, and atherosclerosis. Here is the chart where I said we would talk about the different causes, whether it be maternal, placental, or fetal. Right in the middle are those infections, torch infections, which we're briefly going to review because we've already done those in infectious and in peds, as well as malaria. But that's just a resource. Torch infections, this is from osmosis. You just need to kind of remember, this might show up on your funnel as well, what they are. What does the T stand for? What does the O stand for? What does the R, the C, and the H, torch? Torch infections can lead to miscarriage with stillbirth and intrauterine growth restriction. Brief recap, I'm not gonna read all of this. Don't forget toxoplasmosis gondii is the main cause of toxoplasmosis. This is our moms cleaning up cat litter, cleaning the litter box to come from consumption of undercooked meat. Mom may be asymptomatic. She may have symptoms. What I don't think we talked about in infectious disease was treatment. Spiramycin therapy in women with documented acute toxoplasmosis, because in adults, and we weren't talking about pregnant people, they're usually self-limited, so they don't need treatment. So spiramycin is a treatment you can use. If the patient is less than 18 gestation dealing with an acute toxoplasmosis, remember therapy is going to be more for immunocompromised patients. Immunocompromised patients, if this is a healthy mom, then she may not need treatment. There are some other treatments listed there. Don't need to necessarily know those. And you don't need to necessarily memorize those. Our O, our others, syphilis, DSV, varicella, parvovirus, D19, and HIV. Signs and symptoms depending on what the infection is from. Those are some of the complications: saddle nose, Hutchinson teeth, those notched teeth, mulberry molars, just like a little mulberry fruit over there on those teeth. Favors shins, which is the deformity of the tibia. Rubella, don't forget rubella is an RNA virus, it's a respiratory droplet. Do not give that vaccine during pregnancy, it is for post-birth, we talked about that during the prenatal lecture. Do not give rubella vaccine until post-birth. Do not give it during pregnancy. And these babies are born with a blueberry, or they have a blueberry muffin rash, might be a non-pruritic maculopapular red rash. This again, you should know for your final. Just some of those things that we talked about in infectious. Moms are at highest risk during the first trimester. Infection in the first trimester does lead to congenital rubella in 80% of fetuses. We want to avoid that. Vaccinate after birth to avoid giving it to the baby. Cytomegalovirus, CMV, we talked about this. We talked about the difference between CMV and EDV during infectious disease. What we want to remember here is that it is part of the herpes family. Highest rate of transmission is in the third trimester, usually asymptomatic. It's not well, the treatment is not well studied in pregnant women. We want to educate. They need to remember hand hygiene, sharing food and drinks, because most pregnant women are getting CMV from their babies, especially those in childcare. Seen that picture before, pulled it right from the infectious disease lecture. Those are your key things to remember in pregnant women for CMV. Herpes. Herpes type 2 is the most common. 50 million people in the United States have herpes. There is an increase in HSV1 that we're seeing in some populations, especially young women and men. You can transmit herpes without lesions. You don't need to see the lesions to transmit it. What does an active outbreak look like? Lesion, typically 1 or 2 vesicles, small, 1 or more vesicles, small blisters on or around the genitals, the rectum, or the mouth. This would be a problem during delivery. You want to give antiviral prophylaxis during the third trimester, cyclovir or valacyclovir. Babies who are born to women who acquire their herpes close to delivery are at a higher risk for developing neonatal herpes. So you'll see those pictures that are compared there. The risk of transmission, 25 to 50% there on the left. And that's a new acquisition of herpes that you just got it during pregnancy, not that you've had it before, you have established diagnosis of it. The risk of it is 1% for that because of antibodies. So if you get a new diagnosis, that is more dangerous in terms of developing neonatal herpes. So we want to educate moms about risky behaviors if they are at risk. We have some of the complications down at the bottom, review. That brings us to the end, but I do want to talk about Black Maternal Health Week that just ended, because Black women are 3 times more likely to die in pregnancy than their white counterparts, 3 times more likely. And a lot of this is from the same disparities that we see in other medical conditions. So what can you do as a provider? You want to teach them about maternal warning signs. What do they need to look for? What is abnormal in pregnancy? You want to help them manage their chronic conditions if they have hypertension, diabetes, depression. You want to talk to them about this. Depression, postpartum depression is also higher in Black and Latino women than their counterparts, and they usually don't get screened or get help for it. You want to recognize and eliminate unconscious bias. Make sure you're providing respectful quality care to every single patient. Respond to any concerns that they may have. Serena Williams, tennis player, a big advocate for Black maternal health because she almost died during pregnancy. Even Serena, they weren't listening to Serena. She had to have an emergency C-section because her baby's heart rate dropped and she felt short of breath. She had had pulmonary embolism in the past and felt like she was having another, I have another blood clot. Asked for a CT scan, asked for blood thinners. The nurse said, "You're delirious. This is your pain medicine. This is just your pain medicine talking. You're fine." She demanded, "I want to see the doctor. I want to see the doctor." They finally gave into her request and did a ultrasound of her legs, but they didn't see anything. And so, they're like, "Oh, you're normal, you're normal." She persisted and persisted, finally gave her a CT scan, and heparin, and they found many, many blood clots in her. Many. She required bed rest for 6 weeks and surgery. So definitely listen to your patients. Of course, sometimes patients are dramatic, but make sure you're at least considering listening to them, because they may be having serious issues that you're not aware of. Question. You picture Professor Juicer in there. What people think versus reality. I wonder when they'll start walking, but you're really thinking about sushi and hoagies and margaritas and cheese. How it looks versus how it feels. So I did put some additional resources. This was at your antepartum. This was pelvic pain and vaginal bleeding in early pregnancy. I put it on the wrong lecture. So this is a differential, to help you with differential diagnosis. It's in your antepartum lecture though. And then there's some other resources here. Preeclampsia, eclampsia. Any questions about pregnancy complications? Let's move to twins. This is a short one. Fortunately, Professor G is not doing this lecture because she knows a lot of twins and has a lot of twin stories. I'm not. But that's okay.
Did you? Like it's like a party trick.
So these are not inherently dangerous, but they do carry higher risk. And a lot of the conditions that we looked at in complications, one of the risks was multi-fetal gestation. So there are higher risks, including like preterm birth, low birth weight, fetal growth restriction. We just talked about preeclampsia, gestational diabetes. We just talked about placental eruption, which we talked about. These require careful monitoring to mitigate the risk and ensure best outcomes for both mom and fetus. So, multiple gestations, twins. Probability of having twins is about 1 or 90 in the United States. 1 out of 80 or 90 pregnancies will result in twins. Does anybody have their twins?
Who? We have to see a picture.
Are you guys?
Yeah. There's 2 of Jay.
All right, so
Wait,
2/3 of twins are diagnostic or fraternal.
so they're
Fraternal twins.
they're fraternal twins. I need to.
1/3 of twins are monozygotic or identical. So fraternal is dizygotic, mono is identical. So we'll talk about the differences there in a second. We also think of multiple gestation as triplets or quadruplets or more. These are much more unlikely. Triplets in natural, not in vitro, but in natural development. 1 out of 8,000 for triplets and quadruplets. You see Octomom there on the side, you might be familiar with her. Those babies are now 15 years old. She had in vitro to have them, as well as her other 6 children she had before the 8. So Octomom has 14 kids. But she had in vitro and then had 8 babies. She
Remember
the world record for the most, babies born at a single birth.
Yeah.
Until this lady had babies.
Oh,
This
my God.
woman in Mali had 9 babies.
All of them were inside her body? Her poor uterus. That's insane. What did she do?
That was a second.
I know. Natural. No way.
She broke the record in 2021.
Natural. How old were they when they were
So
born?
they're non-self.
And 24 weeks. That man has some swimmers. Fucking athletes.
No way.
Even at less than 2 pounds,
That's
that's
2
20
pounds.
pounds of baby.
Plus all the amniotic fluid, plus everything else, blood flow.
Hell no. Yeah,
She definitely couldn't walk.
there was no, she had to have been on bed rest from
Those are
literally
non-public.
the second trimester.
They're the only non-public.
They are really
There were
Little in the bread.
non-4, but none of the feet survived.
Oh, I
So
love
the
the
baby,
baby.
after a few weeks, none of them survived. So she's the only one with survived.
It's not 9.
All of
Okay.
them.
Wait, they didn't?
Here's a familiar face with
Oh.
twins that she knows. Those are dizygotic twins, even though they look very, very similar. Dizygotic or
You put her in
fraternal twins
outfits.
are fertilized by two
Yeah.
two eggs are fertilized by 2 sperm. So this occurs in about 1 out of 300. Each twin has their own placenta, each has their own amniotic sac. Risk factors, maternal heredity, ethnic backgrounds, things that happen more in Africans versus Caucasian and Asians, maternal age over 35, and of course fertility drugs. So dizygotic, think diverse, they look different, fraternal, okay? They got their own placenta, own amniotic sac. This is different from monozygotic, which is identical, mono meaning one egg fertilized by the same sperm. The timing of when the ova divides tells us more about what the characterization of the twins will be. If the ova divides in less than 3 days, there will be 2 placentas and 2 amniotic sacs, more than likely, which is about 1 out of 300, which is the same as dizygotic twins. If the division of the egg doesn't happen until between 4 and 8 days, there may be 1 placenta and 2 amniotic sacs. And we're gonna look at some pictures of these. 8 to 13 days, 1 placenta, 1 amniotic sac. That's much more rare. And then even more rare than that, after 13 days, if the egg isn't dividing, you might have conjoined twins, which there have been conjoined twins in the news recently because there was a pair of conjoined twins, one got married.
We got married to each
A
other.
lot of questions.
No.
No,
got married
like
to
one
a man.
got married to a man.
Sorry.
No, the other one's She's happily just present. single.
Like turns away.
And she just reads a book. You know?
Should she read the book?
Reads a book.
I would need music.
Story, a lot of ideas there.
I need some noise canceling. Do they share a vagina?
Yes, they're conjoined at the abdomen.
So she feels it.
Yes. No.
It's so fun.
What book?
Probably. Yeah, what book?
So these are some of your pictures.
What book is good enough to distract you from literally being fucked?
Amniotic sac.
I don't know, but I don't want to read that.
Placentas, 2 amniotic sacs, 1 placenta, 2 amniotic sacs.
Like,
Those are the different versions of that, mono,
This is
amniotic,
strong, man.
monochorionic. So remember, amnio is the amniotic sac, chorionic is gonna be your placenta. So that's how they talk about those, this is just a resource.
Yeah, like, right?
What are some signs that you might have a multiple gestation or you might be carrying in twins? If your dates don't match, the baby is large for gestational age. Did ultrasound and gosh, that baby's big, when you say your last little period was, could be more than 1 in there. If you have excessive weight gain, we talked about different, kinds of weight gain in our prenatal. So if they're gaining more weight than they should be, that may be a sign. If they have high levels of HCG or alpha-fetoprotein, that could be a sign of increased, or more than one fetus. Unfortunately, hyperemesis, that severe form of nausea and vomiting we talked about last time, hyperemesis gravidarum, that is sometimes, more, common in patients who have multiple gestation. It's a lot of movement in there, more than what is expected, that could be a sign. And then if the fetal heart rate is heard in 2 quadrants. Clinical exam misses about a third of all twins. Surprise, there's more than one. Surprise. The, non-celibate moms for most of her pregnancy, she thought she was carrying 7. Until she got to Morocco where she delivered the babies, and then they said, oh, there's actually 2.
Yeah, at that point. It's a machine gun.
It's literally like a dog.
Wait, it's like, oh, she's having.
Yeah.
So what are some of the risks? Pregnancy induced, they have, more pregnancy induced hypertension, 3 times more likely than single gestations. Postpartum uterine acne, which we're gonna talk about in our next lecture, which is basically when the uterus relaxes and isn't contracting like it needs to be, which will result in a result in hemorrhage. They also are at more risk for having to have a cesarean section. For the baby, placenta previa, which we talked about, placenta previa, when that baby is sitting over the internal os, it can be complete marginal, where it's completely over, partially over, or at the edge. We talked about that. Is that painless or painful bleeding?
Painless.
Painless, right. Abnormal insertion of the cord, where the cord is inserting. Spontaneous, premature rupture of membranes, intrauterine growth restriction, we just talked about. 50% of these, result in preterm labor. I think non-tuplet mom had hers, I feel like it was 28, 27, 28 weeks, 30 weeks. It was early. She wasn't gonna be able to carry full time. But they did stay in Morocco in the hospital for 19 months. Or they stayed in Morocco for 19 months. I don't know exactly how long their hospital stay was, but they had to stay with that specialized care for almost 2 years of their life. They also. They are 3 or 4 now. I think they were born in 2021. So yeah, so they're also at risk for malposition, or both heads down, one head down, one head up, cephalic, breech, different types of positions, which we're going to talk about more in labor and delivery. This is rare, so you know how I feel about rare things. I do want you to be aware of it though. Twin-to-twin transfusion syndrome. This occurs in about 15% of monochorionic pregnancies. Monochorionic meaning one placenta. They share one placenta. It is due to an unequal flow of blood between the twins. One twin is called the donor, which you'll see on the picture, and the other twin is called the recipient. But it can lead to problems for both babies. There is a size discordance on the ultrasound. Can be up to 25% size difference. Usually this is discovered in the 2nd trimester. The donor twin, the little one, is giving away more blood. It's donating more blood. So it's a donor. It's giving away more blood than it receives in return. So it runs the risk of malnutrition, which is why its fetal growth might be stunted. May also lead to organ failure. Because it doesn't have as much blood, its kidneys don't have to filter out as much blood, so their urination decreases, which could lead to what with the amniotic fluid. It's right. Low amniotic fluid. Or the recipient twin, they're receiving too much blood, but this can also be a problem because it can overwork their heart. So they're in a state of hypervolemia, too much fluid, too much blood. They have increased urination. They can have too much amniotic fluid, which can lead to polyhydramnios, which can lead to heart failure, eye drops, or fecal demise. So it is a problem. It could be a problem for both twins. Without treatment, 70 to 80% will die in utero. So a lot of these moms have to have surgery. We'll look at the next slide, but you do not need to know the treatment for this. One, they can either reduce some of the amniotic fluid, or they'll do a laser ablation where they eliminate the anastomose placental vessels so that they can spread equally. But again, you don't have to know this, just be familiar with it for rotations. Fetal malformations, congenital abnormalities are 2 to 3 times the rate of a single gestation, a single pregnancy. It could be due to placental blood flow and crowding, which can contribute to certain anomalies. Neural tube defects, GI abnormalities or cardiac issues. Remember my friend that grandson had the gastroschisis. We talked about omphalocele and gastrophysis where the organs are outside of the body, one in a sac, one without a sac. She sent me a picture. That's her grandbaby after birth. All the organs on the outside of the body. Remember, I said he passed, not from that, because he really did well with all the surgeries, but complication from the UTI. So he is a twin. So that was why I brought that up. He was a twin. So they are more risk for gastrointestinal abnormalities. And then we just talked about later cleavage of the egg resulting in conjoined twins, which there's a picture there. They share a liver and diaphragm. They have a separate stomach and heart. Those twins have a different setup than what you were talking about. Umbilical abnormalities are also common in multi-gestations. The highest risk is with the monozygotic and monochorionic twins. So if there is one placenta, it seems to be more risk with that. Typically, we have 2 arteries and 1 vein present, called a 3-vessel cord. In these pregnancies, they only have a single umbilical artery and a single vein. So it's a 2-cord, they call it a 2-vessel cord or a single umbilical artery. That's a problem for babies. They can also have, we talked about insertion of the cord, where the cord should attach to the center, but instead it attaches other places. Vasoprevia, we just talked about placentaprevia. Vasoprevia is when the vessels connecting to the umbilical cord to the placenta lie over the birth canal. So in placentaprevia, the placenta was lying low. In vasoprevia, the vessels are lying low. The problem is those vessels aren't protected. So if you have a baby and you're trying to push vaginally, that might be a huge problem. We are not going to do a vaginal birth for those, because they're going to rupture all those vessels. Probably mom's going to hemorrhage. So keep that in mind. Umbilical cord entanglement is common in twins, which is why they sometimes will get delivered sooner than later. Or a cesarean section may be recommended, which we'll talk about later in labor and delivery. Question. All right, Jay, you're famous now. What's going on? All right, guys, let's take a 10-minute break, and we're going to come back with labor and delivery. Detail. The goal of labor is, of course, the descent and the expulsion of the fetus. Expulsion, get it out.
Get out of here.
Labor may begin spontaneously, or it could be induced medically. Determining the onset of labor requires subjective and retrospective data. So when do the contractions begin? How regularly spaced are the contractions? Is the cervical changing? Is it dilating? What's occurring with changes in the cervix? Those are all going to help us determine what's going on in labor. So first, we're just going to do some brief vocabulary. We'll talk about these. For this lecture, some of this stuff is going to be repeated at the end. So we'll talk about the vocabulary. So you'll understand what these terms mean, like effacement, Effacement is the thinness and the length or shortness of the cervix. So in pregnancy, the cervix, as we get ready for labor and delivery, remember, we're getting ready for labor now. The cervix is stretching and getting thinner. You can see a picture of effacement at the bottom and what the size of the cervix, what that length of the cervix looks like at 0 effacement, which means it hasn't done anything. At 30% effacement and 100% effacement, and you can see that peach colored change is how much it's thinned out. As the baby's head drops down into the pelvis, it pushes against the cervix, and this causes the cervix to relax or efface. So that, think about, you have a baby pushing, eventually it's gonna get that thinner and thinner and thinner. Some labor and delivery nurses say that effacement can feel like paper thin. So we'll look at that again later in the lecture. Effacement is often a precursor to dilation as the cervix prepares for childbirth. What is dilation? Dilation is when the cervix begins to open, and it is assessed on a scale of 0 to 10 centimeters. 0 being closed. 1 is about the size of a Cheerio. 2 centimeters, about the size of a penny. 6 centimeters, about the size of, looks like a Chips Ahoy cookie. And a 10 centimeter is about the size of a bagel. So your cervix goes from closed Cheerio to bagel. And that's when the head and the body can work. In order for a mom to start pushing, you have to be 100% effaced, 10% dilated, for a vaginal delivery. So that's when you'll hear terms like 100% effaced, 6 centimeters dilated, 10 centimeters dilated. That's what they're talking about. Fetal station refers to the position of the baby's head in relation to the mother's pelvis during labor. It's a measure of how far down the birth canal. So you'll use the ischial spines there with the red line to help you determine this measurement. At 0 station is when the baby's head is actually at the ischial spines. Any of those negative numbers, the baby is higher up into the pelvis. Once the baby starts to come down, then the numbers become more positive. So for example, a -3 station means the baby's head is still high in the pelvis, while +2 means it is below the ischial spines. Usually at +3, you have crowning. So, we see crowning with growth stations. So those kinds of things. All right. What is the presentation? So we just talked about the presenting part. Presentation is the part of the baby that is overlying the maternal pelvis. So there's several different presentations. Usually the head leads the way. However, sometimes the butt, the shoulders, or the face leads the way. And we'll talk about this in a second. The first position listed is occiput cephalic anterior. This is when the head is down. Another word for head down is vertex. So if you're going into OBGYN, you may hear vertex or cephalic or head down. The face is towards the back and the back is towards the belly. So you'll look at the picture at the top, occiput anterior. So you can see the face is towards mom's back and the baby's back is towards mom's belly. This is ideal. This is the best birthing outcome usually, that position. The position next to that is where the baby's opposite. So the face is now, the back is towards the belly. I'm sorry, the back is towards, the face is towards the abdomen. So the face is towards the abdomen there, the back is towards the back. They call this sunny side up because the face is looking upward. This patient is at a high risk for prolonged pregnancy. Very painful pregnancy. And we're gonna talk about this because there are several cardinal movements my baby has to make to get out of the pelvis. So we'll talk about why this is not ideal.
Okay. So
Other presentations,
next.
front breach, footling breach, and complete breach. And there's pictures of those at the bottom. Front breach, the baby's buttocks lead the way. The hips are flexed and the knees are extended. In this position, these babies are at a high risk for umbilical cord loop and fetal injury. Footling breach, foot, 1 foot pointing toward the birth canal, okay? So also on this one, it's not, it is another breech presentation. One or both of the hips are flexed and 1 foot is pointing towards the birth canal. You see that one little leg raised. These babies are at a risk for umbilical cord, the umbilical cord cutting off their blood supply. The least common of the three is complete breach, which this little baby looks like he's going to do a cannonball into the cord. So his butt first, hips and knees are flexed, he is ready to go. So complete breach, the least common of the three. Another position, which you'll see in another picture, is transverse lie, which is another presentation. For these babies, their shoulder will likely enter the birth canal first. These babies usually have to be delivered by C-section. It is very hard to maneuver the baby to get it back to a position to come through the pelvic inlet. So most of those babies are gonna have to be delivered by C-section. We have those there. We're still doing definitions. Fetal lie. This is the relationship between the long axis of the fetus with respect to the long axis of the mother. Normal fetal lie is up and down, so the baby's longitudinal or parallel. The crown is at the head of the cervix. So that's the cephalic or vertex position. Baby is up and down or oblique, which is kind of turned sideways, or transverse, which we just talked about, which is where that shoulder more than likely is going to come out first. So that's the lie, the relationship between the long axis of the fetus and respect to the long axis of the mother. Fetal attitude does not mean the baby's trying to get. It increases, it describes the position of the baby's body part. So the flexion is the first picture. That is normal fetal attitude, where the baby is tucked, their head is tucked down to the chin, and the chest and arms are drawn in towards the center. The back is curved on that. That is normal fetal attitude or flexion. That's what you want. Deflection, which is the one in the middle, is when the baby's back is straight. And extension, you can see that that is the face up.
A liar and a thief.
And you'll see why this is a problem when we look at the pelvis here in a second. Why that certain positions won't quite work. Or are harder than others. Position. This refers to the direction of the presenting part of the fetus in relation to 4 quadrants of the maternal pelvis. You may hear ORP, LLP, LLT, ROA, stand for. Basically, it tells us that the fetus is facing backwards to the right or the left, or the fetus is facing forward to the right or the left. So if the baby's face forward, backwards. So where is the occiput? The back of the head. Where is it? Is it laying? This is towards the right. Anterior versus posterior. Where is the occiput? The occiput's here closer to the front. Occiput's there in the back on that one. That's how you describe those. Right, left, anterior, posterior. Okay. Clinical correlation. Classifications describe all aspects of the fetal position. What is the lie? Is it longitudinal, vertical? Presentation, is it vertex or cephalic? The reference point is the occiput, the back of the head, that bony protuberance in the back of the head. Attitude is general flexion. These are things that you want. Most babies are settled into this position between weeks 32 and 36. Ideally, we want that head down, facing the mother's back, chin tucked, just like in that picture. All right, let's get into it. 4 stages of labor. Number 1, the onset of true labor to complete dilation of the cervix. So from true labor versus false labor, which we'll talk about in a second, to the complete dilation of the cervix. And what is complete dilation of the cervix? How many centimeters? 10. The second stage is from complete dilation of the cervix to the birth of the baby. Stage 3 is the actual birth of the baby to the delivery of the placenta. And stage 4 is from the delivery of the placenta to the stabilization of the patient's condition, which is usually about 4 to 6 hours postpartum. So those are our 4 stages, which we're going to get into detail about each one. So stage 1, the longest of the stages. This begins with slow cervical effacement and dilation. We just talked about that. Effacement is that thinning of the cervix. The baby's head is pushing down, thinning out that cervix. And then dilation of the cervix, where the cervix actually is thinning out and starting to open. It ends with rapid, complete that cervical dilation. There are 2 phases of stage 1, latent and active. The latent phase begins with cervical changes in the presence of regular contractions. So this can be slow. Patients usually going from 0 to 6 centimeters, can take up to 20 hours if you've never had a baby before. Or longer. If you've had babies, it might take up to 14 hours. That first stage of the labor, from getting from 0 to 6. The active phase begins with the increasing rate of cervical dilation. So once you start to dilate from 6 to 10, that is your active phase. Usually at this point, they're dilating about 1 centimeter per hour. The presenting part of the fetus, whether it's the foot, the head, the butt, begins the process of engagement into the pelvis. During this phase of labor, you're going to be doing cervical exams. Labor and delivery nurse is going to be doing a lot of this, determining the position of the fetus, how much the cervix is dilated, and how much it has to face. Stage 2. Now we are completely dilated, 10 centimeters. We're getting ready to have this baby. The fetus will start to descend into the vaginal canal and is delivered, which is usually when moms feel that desire to bear down. And then you start to push. Okay, we're ready for you to start to push now. So for a nulliparous woman, if she's never had a baby, we do not want her pushing more than 3 hours. She should be pushing less than 3 hours. If you've already had babies, usually it only takes about 2 hours. But for some women, it can take 5 minutes to get that baby out, or 30 minutes. It can be very quick, especially if she's had more than one. It is considered prolonged if the stage lasts more than the times above. So if she's been pushing for 4 hours, that's prolonged. If she's multifarious and she's been pushing for 3 hours, that is prolonged. That is going to go into our dysfunctional labor, which we'll talk about in a little bit. Some of the influencing factors on duration of stage 2 is related to position of the fetus, the fetal size, the shape of the maternal pelvis, which we're going to go into. If the mom has any comorbidities, she have high blood pressure, does she have gestational diabetes? And also, what is her history if she's delivered before? So these are things that will influence how long this stage lasts. How long did it take you to deliver your first baby? It's kind of fun. I'm gonna find out. Stage 3. This begins immediately after the delivery and ends with the placental expulsion. Sydney, show your work. So mom's delivered the baby. Oh, she feels great relief. There's still a lot going on in this stage because we need to deliver the placenta. So in this phase, the uterus or the womb will continue to contract. A lot of moms say this feels like menstrual cramps. So it's a less painful contraction, still pretty regular in time. But during that time, those contractions are causing the placenta to detach from the uterine wall. So you see that placenta starting to migrate its way out. Usually it's a spontaneous expulsion. Sometimes there may need to be a little bit of help with that. Of course, if you have a C-section, they're just gonna take your placenta out. But usually mom will have to push one more time. As it starts to make its way, we'll talk about pulling on the cord a little bit, kind of helping mom get that out. Typically delivered within 30 minutes. Some people can take less than 2 minutes. Some people it may take about an hour. Sometimes moms are given medication to kind of help that wound continue to contract. And we want to minimize bleeding. What hormone did we talk about, folks, with uterine contraction? Oxytocin. So they need to give them Pitocin, which is a synthetic form of that, to help with this stage of labor. Stage 4. The hour following delivery in the first 4 to 6 hours postpartum. Going to continue to closely monitor mom. Those are just your 4 stages. So let's talk about true and false labor, because we said that the first stage is true labor, is when it starts with true labor. So there's true labor and false labor. Some things that will indicate whether it's true or false is the regularity of the contractions. So if it's a regular contraction pattern, it's happening eventually, this is what you want, every 45 to 60 seconds with 3 to 5 minutes of rest in between. Every minute, basically. With 3 to 5 minutes of rest in between. Other people may have contractions. Though I had a contraction, but that was 30 minutes ago. I had a contraction that was 20 minutes ago. That's more likely false labor. The intensity of the contractions goes up. So it gets worse. And false labor, they stay about the same. Well, I had a contraction 20 minutes ago. Had another one that felt the same. If you're having true labor, those contractions are going to get worse in intensity. They're going to feel worse. They're going to have more pain, lower back discomfort radiated to the abdomen. Where in false labor, they may have discomfort, but it's not as bad as true labor. It's more mild. They usually don't have any specific pain location either. For true labor, let's just try to walk it off. It's probably not going to walk off. Where in false labor, it might. We relieve. And then the big thing with this, I'm having contractions, my stomach, I'm having its pains, and then you do a cervical exam, and they're less than 2 centimeters. They're not changing at all. Where in true labor, that progression, that 0 to 6, 6 to 10, you're gonna see that progressive change in the dilation and the effacement. So this is a big one, because a lot of women go to labor and delivery in the emergency room for false labor. I'm having these contractions and they're really Braxton Hicks. Braxton Hicks, most women will experience these at some point during their pregnancy. This is the false labor. These are not associated with progressive cervical dilation or effacement. So we said if it's under 2 and that's changing, more than likely false labor or Braxton Hicks contraction. These are very common in the last month to 2 months of pregnancy or the last 4 to 8 weeks of pregnancy. These are irregular, usually not very painful. Not to say that they're not uncomfortable, because they can be. But they're usually not as bad as a true labor contraction. One significant trigger for Braxton Hicks is dehydration. If you're busy, you're preparing you 4 weeks out and you're trying to get ready for your baby, you might forget to drink water, and sometimes I would say it's probably one of the most common triggers for Braxton Hicks contraction, dehydration. Some people think of Braxton Hicks as like the uterus practicing for labor. So we talked about if mom is pushing more than 3 hours in the milliperiod or more than 2 hours in the multifarious, that that is prolonged. So we're gonna talk about dysfunctional labor, when things aren't progressing like they should, or they're progressing a lot slower. Maybe this, the cervix isn't dilating, the baby isn't descending like it should. This is sometimes called an arrest of labor, where it just isn't moving forward. So it stops, but not, it's just very, very slowly progressing. It is most common in the first stage of labor. Complications can occur in any stage of labor, but it is most common in the first stage. It is the most common reason for unplanned intrapartum cesarean birth, dysfunctional labor. Some of the risk factors for dysfunctional labor: the uterus isn't contracting as frequently, or it just can't contract strong enough to help push that baby down. There's also something called a Vandal spring, which is not super common, but I do want you to recognize it. You can see the picture of it up at the top, where you had that smooth body, and now you have a big dent in it. And that is a Vandal ring, which is here, that contracting that tissue down. So there's two segments of the uterus, the upper and the lower. One should be thinning, and the lower part is thinning out with labor. And sometimes what happens is this constriction ring forms during the labor, which separates the two segments of the uterus. It's thought to be caused by prolonged pressure of the fetal head against the cervix and a reduced blood supply, which causes those tissues there in the uterus to basically necrose. Disproportionate size of the fetus relative to maternal pelvis, or a cephalopelvic disproportion. What mom might have a cephalopelvic disproportion? We just talked about a complication in pregnancy, where a baby might not fit through. Diabetes, gestational diabetes. So these moms might have some problems as well, because they're trying to get a big baby out of a small opening, bigger than normal. Also, risk factors would be fetal position and fetal malpresentation. So those complete breech, foot length breech, all of those breech positions as well may cause the patient to have dysfunctional labor. All right, the 5 P's of labor. There are 5 P's. These all influence the duration of labor. How long are we going to be in labor? The passageway, the passenger, the position, powers, and psyche or psychology. We're going to talk about each of those so that you can understand why labor may take longer than usual. And we've talked about some of this stuff already. So the first is the passageway. So think of the passageway as the birth canal, the uterus and the vagina. This is your car. How are we going to get this baby out? So we're driving it out. So the bony pelvis is the factor of how we're going to get it out that we're looking at. So this is just the anatomy of the bony pelvis. And you can see the difference in shape of an oval shape for female versus a more heart shape for men. Naturally, just in comparison. Pelvimetry is currently the only method to assess the shape and dimensions of the bony pelvis in labor. In 2017, you can see down on the slide, it says there's not enough evidence to support the use of imaging to decide on the mode of delivery. So we're not going to do pelvimetry to say, oh, you should have a vaginal birth or you should have a cesarean. We're not doing that anymore. There's not enough evidence to support that. In 2018, it actually showed that by doing so, you may increase C-sections without a clear benefit of the birthing outcome. So for most people, adequate trial of labor is the only definitive method to determine whether a fetus will be able to safely, that should be navigate through the pelvis cell check, sorry. You can assess this, usually clinical exam, X-ray, CT, or MRI. If you really want to do a CT scan, That's just something to be aware of, but probably not going to practice much. These are the shapes, so women have different shaped pelvises. The most favorable for vaginal delivery is the gynecoid, which is about 50% of women. It's the most common type. Followed by android. This is not favorable for vaginal delivery. Anthropoid, which is about 20% of patients. This is more favorable for vaginal delivery. Platypoid, 3% unfavorable. So you can see the different shapes of those. I saw a cool little, so when you want to learn OB, labor and delivery nurses are your go-to. They are your best friends. So there are a lot of YouTube videos and things like that. And one way of remembering these, she said gynecoid is kind of shaped like a pumpkin. Looks like a pumpkin. You call your baby my little pumpkin. So you want that. You want a gynecoid shaped pumpkin. So if you're trying to remember the shapes. Anthropoid almost looks like a head, a human head. So you want that one as well. Those are both favorable, gynecoid and anthropoid. Android, if it's a phone or an alien, you don't want aliens coming out of it. Okay, so that's probably not favorable. And then platypoid, you think about the animal platypus, you want a platypus coming out of you either. So those are not favorable. So we want gynecoid or android for vaginal delivery. I'm sorry, not android, anthropoid. So those are the different shapes. You can see the inlet size and look at so there's more other parts of the passageway.
I don't know, I wrote
That we're gonna get through. You also need to be aware of the cervix, the vagina, and the perineum. These can all play a role in how long you're in delivery. The cervical exam, you need to be able to define what dilation is and effacement in those measurements. Cervical consistency becomes softer with effacement and dilation. So we'll talk about the cervix here on the next slide. Typically, it's 2.5 to 3 centimeters long by palpation. Remember, it feels like the tip of your nose. In a nulliparous woman, it is circular os. If you've had babies, it's more of a slit like os. Cervical examinations typically begin at 36 weeks, so we'll start taking a look, see if you start to dilate any. Cervical dilation, we've already talked about some, from 0 to 10. It can be determined by placing 1 to 2 fingers in the cervix and assessing the diameter of the opening. So we talked about a Cheerio to a bagel in terms of trying to compare sizes in your head. The peace sign, it says on here, helps to estimate the distance in centimeters. So you want to basically use your index and your middle finger. 1 centimeter is about a finger's width. So you're actually feeling in there gently. If it's about 1 centimeter, that's about a cent. That if it's about 1 finger's width, it's about a centimeter. 3 centimeters is about the width of 2 fingers. So you're using your middle and your index finger. You're going to feel in there. So you get your 2 fingers there in the opening. It's about 3 centimeters. 4 centimeters are when the 2 fingers are spread apart by about a centimeter. So you're trying to get in there. You're not feeling anything. You get 1 finger in, that's 1 centimeter. Get 2 fingers in, that's about 3 centimeters. If your 2 fingers are spread out, that's about 4 centimeters. The widest stretch you can get your fingers is about 7 to 8. So if you can get your fingers through that hole like this, that's about 7 to 8 centimeters. Okay. We can't measure the baby with the fingers. If you see that head finger, the baby's coming out, then it's 10 centimeters. Fully dilated, ready to go. You need to be able to determine the difference between the internal and external os when you're doing cervical dilation. External os, we know, is the opening between the cervix and the vagina. The internal os is the opening between the cervix and the upper part of the uterus. Cervical effacement we talked about. Cervical thinning and shortening during labor expressed as an estimated percentage. 0% effaced is not effaced at all. 30% effaced is a little bit thinner, and then 100% effaced is when it's completely thinned out. There's no more thinning. It's ready to go. You'll see the picture there, and there's more on the next slide. of effacement, that gradual thinning. And we said the baby's head is pressing down, it is smashing, it is thinning that out. This is not something that you are gonna learn. You probably won't, you may not even learn it on your rotation, because this takes a lot of practice. Measuring effacement takes a lot of practice. And I'm not sure, even on your rotations, if you have enough exposure to really, really get a good feel of, oh, that's 50% effaced, or if that's 90% effaced. Definitely your dilation, yes, but effacement is a little harder, and it takes a while, even for labor and delivery nurses to get that skill. So, that's just another diagram for effacement. And then 10 centimeters dilated, that's what that looks like. So the baby's head is about 10 centimeters dilated, and that's probably what most dads are looking like in the delivery room. That's coming out of where? Next part is the passageway, the vaginal canal. So the vaginal canal typically is about 2 to 4 inches in length, but it really depends on the patient's age and weight. There are different factors. It is designed to stretch and accommodate delivery. So it will stretch out, and it can take about 6 months to a year to completely heal. So you can see the top picture, that baby trying to migrate through, and the vaginal canal having to stretch to accommodate that baby's coming. Sorry about the graphic picture at the bottom. The real deal. Okay, so that's the passageway. Now we're gonna talk about the passenger, which is who's driving the car, the baby. The baby is the passenger. He's the rider. He wants to take a ride. Want to come on out. So one of the first things we're gonna look at is the size of the fetal head. The fetal presentation, is it cephalic or vertex? Is it breech? Is it shoulder coming out first? So the presenting part, what part of the fetus is entering the pelvic inlet first, which is closest to the internal os, that fetal presentation. These are all things we need to consider. Consider the fetal lie. We talked about that. We usually want longitudinal. That's the relationship of the long axis and the maternal long axis and the fetal long axis. We talked about that versus transverse or oblique. The fetal attitude, which is that fetal flexion, that chin tucked towards the chest. The fetal position, the station. A baby is at the ischial spine at 0. The baby's head is engaged at 0. 3+ is crowning. So remember your positives and your negative numbers for station. And we talked about engagement being related to that. So the baby's head, the fetal head circumference is greater than or equal to 35 centimeters within 1 week of delivery. Is an independent risk for an unplanned C-section. So if the baby's head is 35 or greater, if it's 35, if it's greater than or equal to 35 centimeters, this mom might need to do a C-section. The baby just might not get out of the pelvic inlet. There is a number system that they use. The newborn's head is half of the baby's body length in centimeters plus 10 centimeters. I put an example in the note for you of how to measure that. I don't know if you would ever have to do that, but that's something just to be familiar with. Biparietal diameter is the widest diameter. So you can see that the purple line at the top, how wide is the head in the cephalic presentation. Usually measures about 9.5 centimeters at term. So we'll look at the next picture, which shows us why those positions, why that chin tuck is such an important thing, because of that 9.5 centimeter diameter. If the baby's head is positioned in other way, if the head is flexed, or if the baby is straight up and down, that size is greater. So you went from 9.5 centimeters wide to 12 centimeters wide to 13.5 centimeters wide, just because of the position of the baby's head. When the baby's up, that smaller part is able to come out versus the wider parameters you'll see in those different positions. So the baby's head is just too big to enter the pelvis, which is why you want the baby in flexion. You want the baby's chin tuck, back curve. You want that little position, so that smallest part of the head can fit through. There's some big names for this suboccipital pragmatic diameter. I don't need you to know all that for your test. You can be familiar with it for your rotation. All right, presentation we talked about already. Cephalic occiput anterior is the more ideal. But there are others, that we said these are more mouth presentations. This refers to the fetal part of the body that presents again. Breech usually requires cesarean. Occasionally, they are able to turn babies around, but that does not always work. So you can see a picture of a shoulder presentation down at the bottom. It's almost impossible to move that baby around. So most of those are under these exceptions. So just more examples of that. The lie we talked about, this is the longitudinal axis. Again, a lot of this is repeated. We went over the definitions. So this is just pictures of that longitudinal. Longitudinal can be vertex or breech. Transverse is not ideal. Cannot have a vaginal birth with transverse lie. Fetal attitude, we just talked about selection, this desired position that we want, where the normal head is tucked to chest and extremities are drawn towards the center of the chest. Versus extension, or that face first. Remember, that's a bigger size diameter of the head that has to come through. Position, the orientation of the presenting part of the fetus with respect to the four quadrants of the maternal pelvis. We talked about this already, LOP, ROP, ROA, LOA. So a lot of this is repeated. What is the position of the baby? There's the head, is the occiput towards the front, the back, the right, the left. And that is based on those four quadrants of the maternal pelvis. Stages, we already talked about. 0, the ischial spine. -3, negative numbers, probably not engaged. The baby's starting to drop and ready to go. It's gonna be more positive numbers. Talk about this. Leopold's, we talked about during the antepartum part. We use this to determine position, presentation, engagement of the fetus. Remember, we talked about the different positions. The last one, you're turning towards the feet of the mom. This can help you determine the presentation and the position. So you go back to your antepartum and look at that again. But this is gonna help you determine where your passenger is in the labor. Moms usually do not like Leopold's maneuvers, but they're necessary. They don't feel good. Ultrasounds can also confirm presentation and position. So now we're moving on to powers. We talked about the passageway, talked about the passenger. Now we're gonna talk about the power. How are we gonna get this baby out? So the first is the contraction cycle, which is the overall pattern of the contractions. We describe these in frequency, duration, and intensity. So what is the force of the uterus? Duration, how long the contraction lasts. The start to the end of the same contraction. Is it 30 seconds, 45 seconds, 60 seconds? The frequency, how often are they occurring? Every minute, every 3 to 5 minutes, every 10 minutes, every 20 minutes? So it's the start of one contraction to the beginning of the next. The intensity, how strong are they? Reported usually as mild, moderate, or strong. All right, so part of the contractions, we'll need to discuss the amniotic membrane. When the amniotic membrane ruptures or the water breaks, this usually signals the onset of childbirth. And for most moms, in terms of starting the labor, usually around after 37 weeks gestation, the baby's ready for birth, and the amniotic membrane will rupture spontaneously. Sometimes it will rupture prematurely, so that's before 37 weeks gestation. Remember, we talked about full-term infants and preterm infants. You needed to know those numbers. 37 weeks, if it ruptures before 37 weeks, it's a premature rupture of membrane. True labor can begin without rupture of the membrane. True labor can begin without rupture of the membrane. You might need to rupture the membrane to induce childbirth. The rupture is usually caused by uterine contractions or just natural weakening of the uterus over time. That baby is just sitting there pressing, heavy, 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 and the uterus just weakens and the amniotic fluid will just rupture. There, on the picture, you'll see two different types: a high leak, which is just more like a trickle of fluid, and a low break of the amniotic rupture, which is a gush, which some women will talk about. So like a gush of water came out of it. If a mom has a prolonged pregnancy, or she's beyond her due date, maybe she's got gestational diabetes or high blood pressure, you might need to artificially rupture the membrane. Diabetes, hypertension, or beyond their due date. As a provider, you're gonna look for signs of rupture. You're gonna look for pooling of amniotic fluid in the posterior vaginal vault. If you're not sure if it's amniotic fluid or not, you can do pH testing or burn test, which we're gonna talk about. And that bottom picture just shows an amnio hook, which is gonna help rupture the membrane. Amniotic fluid pH is about 7 to 7.5, which we're gonna talk about on the next picture. So you're gonna do a sterile speculum exam. Again, you're looking for pooling of amniotic fluid in the posterior vaginal vault. Usually you'll see clear fluid flowing from the cervical canal. You can do a nitrazine paper test, which is at the bottom. So your normal pH is a lot lower than amniotic fluid. So anything above 6.5 would be consistent with ruptured membranes. You see that at the bottom. And it just goes back to bacterial vaginosis is having a higher than usual pH, for example. Another test is called the Fern test. And the Fern test basically looks under a microscope to see what the fluid looks like, and that looks like the little fern, like fern leaves, that is consistent with dry amniotic fluid. Other ways to check the strength of the contractions, we're still in powers, is a dynamometer or TOCO test. Intrauterine pressure catheter and fetal scalp electrode. So for these tests, we're trying to test the strength of the contractions. The TOCO is the less sensitive, it's a little less sensitive than internal monitors. So the intrauterine and the fetal scalp electrode are gonna be internal monitors, whereas the TOCO is an external belt. See the picture on the far right side, that's gonna be TOCO testing, which is ideally what you see on in a lot of labor and delivery units. The most accurate assessment is gonna be with the intrauterine pressure catheter. This may be used after rupture of membranes, but not before. This can typically pick up contractions better in an obese patient. You think about more adipose tissue in addition to the uterus and all that's going on there, might be harder for the TOCO to pick up contractions. And then fetal scalp electrodes, which are the best measurement of fetal heartbeat. We're going to talk about fetal heart rate accelerations and decelerations later. What you would consider doing a fetal scalp electrode if the patient is laboring and with ruptured membranes, and, we're just not very satisfied with what's going on. It's just another test to help you try to test fetal wellness. The next P is psychology or psyche. So we need to think about the psychology in addition to the anatomical part of labor. The stress a mom is under, anxiety she may be feeling, fear she may have, all of this impacts labor. So you need to be a comfort. Be as comforting as you can. Try to instill trust. You want to incorporate their beliefs and cultural beliefs and values. You might, they might have calming music, massage, aromatherapy, help them with changing positions, giving them ice chips, talking to them about breathing techniques. Make sure they have, support there if they have support. They may have a doula. I had a classmate who had a reflexologist. She was getting reflex. That's like on her feet. She was like, it was the best thing ever. She had 3 kids and she said it was amazing. So she had somebody come in and do reflexology on her feet. The goal is to have a positive delivery experience. That's the main goal. So 4 stages of labor. Here again, you've seen that picture before. What is the clinical management in the first stage? Well, this maternal activity is going to be dependent upon status of the membranes and the fetal engagement. So what mom is, where mom is at in that first stage, going to be dependent. Has her water broke? Has her membranes ruptured? Is the baby's head engaged? I mean, I know women in the first stage of labor at Target. So, it just depends on a lot of different factors. You want to encourage sideline positions. We'll talk about that again in a minute. We talked about that last week with the inferior vena cava and feeling, when you're laying on your back and not being able to breathe and things like that. That blood vessel is very important in labor as well. We'll talk about that in a minute. The next one, NPO or clear liquids, begin IV fluids. The NPO or clear liquids is dependent on your hospital or your setting. It used to be that as soon as a mom went into labor, no more food or drink. That was because in the past, with C-sections, a lot of moms had to have general anesthesia. Now we know that we want moms awake and active during labor. So that is changing, but some hospitals still have a very light diet at the beginning, maybe dry crackers, toast, clear liquids, but it's gonna depend on your hospital. It just doesn't go over well anymore if you're in labor for 25 hours, if you're not eating or drinking, and you need energy to have this baby, then a lot of moms are very hangry. So that is very dependent, but they still do not recommend heavy foods, fried foods, spicy foods, things like that. There was a lot of risk of aspiration. You think a big heavy uterus pressing against the stomach. What hormone did we say relaxes muscle, smooth muscle in pregnancy? Progesterone. So you have progesterone that's not working in your favor, causing more reflux, things like that. So the possibility of aspirating is higher in pregnant women anyway. So, there are a lot of factors in with that food and drink, which is why they still limit what you eat and drink. But again, these restrictions are changing. Maternal monitoring, you want to check vital signs. We're doing intake and output. We're checking uterine activity. We're doing vaginal exams. Pain management and support and fetal monitoring. So labor is an amazing thing that happens to the woman's body. And just all of you have been here before, where you have been in this position and done this thing. For most of you who were born vaginally. And it's about how the baby moves in 7 positions to get out of the birth canal.
I don't remember being born. You drove or
The
something?
movements of labor,
I know it's really rowdy.
matter.
Yeah.
And there are 7 distinct movements that the baby has to make in order to get out of that pelvic. So we talked about first engagement, which is the widest part of the baby's head into the pelvis. Engagement tells us if the pelvis is large enough to allow the baby's head to move down and descend. So we talked about fetal station and engagement. So that's the first one. The baby's head is now engaged into the pelvis. And on the next slide, I've given you all of this in in writing, so you don't have to worry about it. I just think the picture goes better to look at. Descent, so we're now moving down through the pelvis. The cervix is thinning out, it's dilating. Mom is going to start to, get ready to push. Flexion, we talked about flexion. Want that chin tuck, the body curve. So the baby has gone from being engaged, now it's moving down, and now it's getting into that curved flexion position. As the baby's head descends down further, it will most often rotate so that the back of the head is just below the pubic bone. So now it's starting to turn. The pubic bone there. So it's gotten into its position and now it's starting to rotate. This helps the baby's head fit in the shape of the pelvis. And we said the preferable pelvic shapes are gynecoid and anthropoid, remember those. Usually the baby will be face down toward the spine. You can see the spine there, and the face toward the spine. The next position is extension. As the baby reaches the opening of the vagina, usually the back of the head is in contact now with the pubic bone. You can see the back of the head there next to the bone, making its way out. And as the baby is delivered, it will rotate again to be in line with the body. That's your external rotation. And then lastly, after the head is delivered, the top of the shoulder is delivered under the pubic bone, and after the shoulder, everything else kind of just flopping. Okay? So those are your 7 cardinal movements that baby is making: engaging, descending, flexion, starting to rotate, getting that head under the pubic bone, rotating again, and coming down. Okay? Like I said, those are listed on this slide with description at the bottom. These are just the movements again, and another resource to look at. Now we're getting to the pushing and delivery. We'll take a break and then we'll start pushing and delivering the baby. Let's come back at all right, so a lot of steps of management in stage 2. Don't expect you to memorize these, but just be familiar. One thing, we want to avoid maternal supine position. So mom laying flat on her back. This is an increased risk of perineal trauma. Labors are usually longer, more pain. Fetal heart rate patterns change in this position. So we have other positions that we like, when moms on the ball, on their side, on their knees, sitting upright in the bed, but maternal supine we should try to avoid. You want to encourage bearing down at contractions. We're going to be doing continuous fetal monitoring. We'll talk about that in a little bit. Vaginal exams to document descent, we're checking cervical dilation and effacement, engagement, station. You're checking for a nuchal cord, checking the nuchal cord we talked about in the earlier lectures, which can be a sign of abnormalities, congenital abnormalities, genetic issues. I'm sorry, wrong direction. So from vaginal to the descent, we're going to talk about positioning the mom, getting her ready with antiseptic scrub or drape, episiotomy with crowning if needed, which means if there's not enough room, you might have to do a small incision to open that up if needed with crowning. We're going to clear the baby's airway with a little suction. We're going to look at this in the picture. Check the nuchal cord on the baby. Gentle downward traction to deliver the anterior shoulder, upward traction to deliver the posterior shoulder. Going to slowly extract the baby, and cut the cord, and then transfer the newborn to the mom's stomach or the baby warmer. So those are our management steps of the second stage. We don't talk about these. So we delivered the head. We talked about those 7 cardinal movements. So now the baby's head is out. Remember, the occiput is near the pubic bone. So that part of the head is out. This is before that next rotation. When the baby's head is out, you're gonna begin to suction out the nose and the mouth. Then you're going to, deliver the anterior shoulder, support the trunk, support the legs. You're pulling that baby out. Like I said, by the end, after you get the shoulders out, it's kind of like a, and then it's out there. You're gonna clamp and cut the cord at that point. This is a graphic birth picture. That's the baby's head. You can see them being suctioned before they're out. So stage 3 is gonna be your placental expulsion. So we said that baby's delivered, mom feels immediate relief, great relief. But we said there's still a lot going on. The uterus continues to contract. And at that point, the placenta will start to separate from the uterine wall and will need to be removed. So what are the stages? What are the management for stage 3? You are going to examine the cervix and the perineum for lacerations that may have to be repaired after the baby is delivered. Gentle traction on the cord to facilitate expulsion, which is going to be a gentle pulling of the cord while you're applying pressure. That's going to help deliver the placenta. You're going to prevent uterine bleeding. You can do uterine massage. You can also give oxytocin. We talked about oxytocin does what? So, yeah, so we want to prevent uterine bleeding. We want the uterus to relax and not contract. We want it to contract so that it can stop bleeding. Sorry. You want to examine the placenta to ensure complete removal. If you leave a piece of placenta inside, there is a chance for infection. That is also the same as like the retained products of conception that we talked about. So there's bleeding problems, things like that. So typically, once the placenta is delivered, somebody is doing a good look at it, looking for missing chunk pieces. They're looking at both sides to make sure that all of that placenta is out. Some moms have to have emergent D&Cs afterwards if it is not all removed. And then we talked about repairing lacerations as needed. So that is the placenta. Signs of placental separation. Usually the expulsion, like I said, takes about 30 minutes. The uterus, once the placenta is removed or has been delivered, the uterus will become globular in shape and becomes very firm. The uterus will rise upward into the abdomen. The umbilical cord lengthens. These are the, I'm sorry, let me go back and say this again so it makes sense. So this is how the placenta is swollen, which is the uterus as it's coming out. So the uterus becomes firm, globular in shape, it rises up, the umbilical cord gets longer, then you have a sudden gushing blood. Right. So just like this. Sorry, that sounds So there's your picture of the placenta. These are some tears and repairs of tears. This is just a resource, of course. Stage 4 is early postpartum. So we talked about this being the first hour or two to the first 4 to 6 hours of postpartum. Some clinicians identify 4th stage of labor as the first hour after the placenta is expelled and the uterus starts to regain its tone. This begins a process called involution, when the uterus begins to go back to its normal size. So uterine contractions, we said that they help reduce bleeding because they put pressure on bleeding vessels. Where the placenta has detached from the wall. For some women, the uterus might not contract. Instead, it will relax. This is a risk for hemorrhage. Uterine relaxation or uterine atony, ATONY. For some women, the uterus may not contract normally. It could be because they're exhausted. It could be because of uterine fibroids. It could be because of too much amniotic fluid causing the uterus to be distended or too big, or even a big baby. Same thing, the uterus is too big and distended, has a hard time contracting back. Other risks for hemorrhage would be retained placental fragments, we just talked about. Lacerations, that's why you want to check everything after you're finished to look for those lacerations. And then vaginal hematoma. So you want to look in the vaginal wall for hematoma. Management focuses on frequent assessment of vital signs, bleeding, how firm is the uterus. You want to provide comfort measures. We're working on preventing bladder distension. We want to talk about parent and newborn bonding, that is mom and dad. Encourage breastfeeding, and we want to provide mom with food and fluids, especially if she has had a very light diet or has not had much to eat. Labor can be, we said, spontaneous or induced. Induction is an artificial initiation of labor. This stimulates uterine contractions prior to the spontaneous onset of contraction. So if she has not had any contractions and you induce labor, that is what induction is. It is indicated if continuing pregnancy may be risky for mom and or baby. You just continue with the pregnancy and you need to have the baby sooner than later, you might want to induce. These types of childbirth situations take longer than a spontaneous labor, oftentimes. You should not induce labor before 38 weeks gestation unless emergent. So indications might be pre-labor rupture of membranes. So the amniotic membrane ruptured prior to labor, prior to contractions. Any type of hypertensive disorders, we talked about 4 of those. Multi-fetal gestation or twins, intrauterine growth restriction, fetal demise. Of course, the baby is not living or something's going on, you might have to induce labor, unfortunately. Diabetes and placental abruption. Can you have a vaginal birth with placental abruption? Yep. C-section. Contraindications, if they've had a prior uterine rupture, you don't want to induce. If they have active genital herpes, you don't want to induce. Placenta previa or vasa previa, so either the placenta's over the eye or the vessels are over the opening of the cervix. You don't want to induce labor on umbilical cord prolapse. If the baby's in transverse fetal lie, that's going to be a C-section. Any type of invasive cervical cancer, and then category 3 fetal heart rate tracing, which you will learn more about on your rotation. We'll talk about some fetal heart rate stuff. In your evaluation of your induction, if you're going to induce, you need to consider gestational age. Remember, we're not doing this if you are less than 38 weeks. You want to consider the fetal presentation, the estimated fetal weight, cervical exam. They use something called a Bishop score to do this, which utilizes cervical dilation, position, effacement, the consistency of the cervix, and the station. Is it 0? Is it +3? That's a test for that. I'll show it to you on the next slide. And then you may need to provide intravaginal application of prostaglandin E1 analog. I left you a note in there about that. Basically, it's helping to soften the cervix, or what we call cervical ripening, which gets the cervix ready, especially if you're inducing it before the body is ready to do it on its own. And there are 2 medications, don't need you to know those. Those are very detailed and specific. So the Bishop score is here, and we talked about all that it consists of. It's a scale of 0 to 13. I left you a note down there about that. If the patient's score is less than 6, induction is less likely to be initiated successfully. If it's greater than 8, equal to or greater than 8, you suggest that labor will occur spontaneously or induction will likely be successful. So whether or not it will induce or not, or whether labor will happen on its own, you can use a Bishop's score for that. Is the cervix getting soft? Is the cervix beginning to shorten? Is the cervix beginning to dilate? How big is it? How high or low is the baby in the lung? Is it the station? Is it engaged? To induce labor, we use oxytocin. We talked about that, promoting uterine contractions. The difference between oxytocin and pitocin is at the top. Pitocin is the synthetic form of it. We administer pitocin via IV. That allows us to provide a continuous and precise dose. I don't need you to know those specifics, take it on your rotation. Typically, the labor induces, this is a slow process. It should not exceed more than 3 days or 72 hours. If you start to induce labor, we expect the baby to be born within a 72-hour period. Amniotomy is recommended for women with favorable cervixes, and amniotomy is basically the rupture of the membranes. If you go in and rupture the membrane yourself, artificial rupture of membranes. What is a failed induction? You gave the mom the oxytocin, and there have been no regular contractions. The cervix has not changed after 24 hours. That is a failed induction. No regular contractions and no cervical changes after at least 24 hours. Oxytocin should be administered for at least 12 hours after you rupture the membranes before you can determine if failure before you can determine failure. You rupture the membrane with the oxytocin for at least 12 hours. Nothing, no contractions, cervical changes. These patients will likely need a cesarean section if it does not progress. So there's induction and then there's augmentation. So augmentation is a stimulation of labor that began spontaneously. So mom started on her own, but now needs a little bit of help. So this is the process of stimulating the uterine contractions so they are more frequent, more intense, and that she can have the baby. This is indicated in those dysfunctional labors, those prolonged labors, prolonged latent and active phases. You're still giving oxytocin. So we're just helping mom along. She's just not progressing at the rate in which she should. She started on her own, but she's not going to prepare. So you may give oxytocin for that as well. Pain relief. Pain, we know, is a very common symptom. Moms may feel pain in their abdomen, their back, their pelvic floor, their perineum. This is usually caused by uterine contractions, the cervix dilating, and pressure just from the uterus. There are several pharmacological and non-pharmacological approaches in treating pain. You can see mom at the bottom there on the ball. So sometimes position changes. We'll look at those next, the non-pharm methods. These non-pharm methods don't make pain go away, but it helps mom cope with the pain a little bit better. Movement, they encourage you to walk. Let's get up out of the bed. Let's go walk the hallways. Go walk with your family. Frequent position changes. We talked about that left lateral, that sideline position, sitting on balls, squatting, all kinds of different positions. Which position do we avoid? Self-soothing techniques, breathing. Maybe you took Lamaze, you learned some classic techniques for breathing, getting through those contractions, relaxing, visualization, increased endorphins, hypnosis, aromatherapy, water immersion. Aromatherapy is pretty popular. Water immersion, very cool. You can see that online a lot. Massage. light rhythmic stroking of the abdomen. Those are some non-pharm ways you can work on the pain. In terms of pharmacological, neural axil analgesia is the most common, is the most effective pain relief. That's your epidural. Be a combined form of spinal and spinal epidural. There are blocks. Nerve blocks for labor, nerve blocks for delivery, local infiltration of the perineum. There's a tear there that needs to be repaired. You can numb that area as well. There are several narcotics. Typically, we try to avoid narcotics prior to the baby being born. We typically, if a mom can't do an epidural, then that would be something you discuss with like a maternal fetal specialist or something like the anesthesiologist rather, if you needed to use opioids. Because they can cross the placenta, so it's not the most optional. It can cause nausea, vomiting, drowsiness, and respiratory depression. So those are things you need to consider. General anesthesia, we just talked about when we were talking about the aspiration and how they used to do C-sections in the past. I think 5% of women still may have to do general anesthesia. Those are usually emergencies, some type of special situation. And then sometimes if there's so much pain, they can't do it. Sometimes they will elect to move to a C-section. So there's a bunch of different options. Know that your epidural is the most effective, though there are also blocks that you can use. So they're, I think, the resource for your nerve blocks. And then we're going to talk about fetal response. A normal healthy fetus with a normal healthy placenta can tolerate the stress of contraction, usually. A compromised fetus or placenta may not, which can result in hypoxia, fetal heart rate changes, and acid-base imbalances. So our goal is to detect early signs of hypoxia and acidosis and intervene to preserve fetal health. And we do this by fetal heart rate monitoring. I hope you guys watched the video I gave you for non-stress test, but if you didn't, we're gonna talk about all of those. So fetal monitoring methods, there are a couple of different ways that we can do fetal monitoring. The first one is intermittent auscultation with palpation of contractions. So basically, this requires a nurse. This is a 1-to-1 ratio of nurse to patient. And the nurse is going to listen, usually with either a specialized stethoscope or a fetal Doppler. And at the same time, they're going to be palpating the mother's abdomen to assess the strength and frequency of the contraction. So in the first stage, you are checking about every 15 minutes after the contraction. In the second stage, you're checking about every 5 minutes. This is a method that's a little less invasive, more natural, but the results have been comparable with electronic fetal monitoring, but it is a little bit more work and you definitely don't have to have a nurse on standby. So that's one way to check. And then the second way is electronic fetal monitoring. This is using an external ultrasound device in topo, or that intrauterine pressure catheter we talked about earlier, or the one that goes on the baby's head, spiral electrode. So that is an example of a nurse doing the intermittent auscultation with the Doppler and the fetoscope. These are more examples. The external and internal fetal monitoring. The first one, you can see a belt wrapped around mom's abdomen. The belt is uses a Doppler to detect the fetal heart rate, and the other belt measures the length of the contractions and the time between. So if you've never seen someone in labor, you might have seen someone in labor on TV, and you see that monitor and then pulling out the strip and looking at the number of contractions and listening apart and the heart rate's dropping. With the fetal scalp electrode, which we talked about earlier a little bit, the electrode is placed on the part of the fetus closest to the cervix, usually the scalp, which you can see on that second picture. And this device records the heart rate. The uterine contractions are also monitored with a special tube, which is the second portion of that picture, the intrauterine pressure catheter. And that's inserted through the vagina into the uterus. These internal tests can only be used if the amniotic sac is broken. If you do not want to do that, if there has not been any broken membranes. So only after the water's broken, or you've broken water. All right, fetal heart rate. So we're gonna go over terminology first, and then we're gonna look at some. I am going to give you a website that Professor Newman has used in the past, where you can practice reading fetal heart strips if you need to. Some of you, depending on, especially like CAP region, if you're going to CAP region for yours, you will need to understand fetal heart rate monitoring, for sure. Definitely want to be able to read those. So first you want to establish your baseline. What is the baseline on the fetal heart rate? This is your mean fetal heart rate, rounded to the nearest 5 beats per minute for 10 minutes. We'll look at one of those in a second. The minimum baseline duration must be at least 2 minutes. This does not have to be contiguous. This excludes episodes of marked fetal heart rate variability. So we'll look for the baseline heart rate here in a second. Bradycardia is any fetal heart rate less than 110 beats per minute. So baby's hearts beat pretty fast. Okay. Anything under 110 is considered bradycardia. Anything over 160 is tachycardia. So you need to know those baselines. Bradycardia less than 110, tachycardia over 160 beats per minute. Some other terms you'll need to know when looking at fetal heart rate strips: baseline variability, accelerations and decelerations. The primary goal of the fetal heart rate monitoring is to assess the adequacy of the oxygenation during labor. So we're going to look at a couple of different things, how the baby is responding to that stress. The baseline variability is a fluctuation in the tracing, so it's irregular over about 10 minutes. This does not include accelerations and decelerations. We're gonna look at that in a second. Accelerations is a transient rise in the fetal heart rate in response to uterine activity or fetal movement. That's what you want. Remember, we talked about reactive and non-reactive. Reactive is reassuring. That's the one we want, versus non-reactive, which is non-reassuring. So if the baby's heart rate is increasing in response to its movement, that's what you want. That's an acceleration. This is visually evident as an abrupt increase in the fetal heart rate from the baseline, which we'll see. Usually peaks in less than 30 seconds and lasts less than 2 minutes. It is greater than 15 beats per minute if 32 weeks or more. That acceleration. So if you were at 150 and then you went to 165, that would be considered an acceleration. If you're 32 weeks or more, if you're at 150 and you accelerate it to 10 beats per minute, that would be acceptable if you're less than 32 weeks. Look at all of this again. These are just so you can learn the terminology. A deceleration or a decel is a transient decrease from the baseline. So instead of the heart rate going up, it goes down. This is usually in response to environmental changes for stress. So let's look at a normal fetal heart rate. So what would you assume the baseline is for this patient? The fetal heart rates are at the top, uterine activity is at the bottom. 150. Correct. It's about 150. The bottom line, the bottom picture shows you the beginning of the contraction and the end of the contraction, and that's going to matter when we're looking at different types of variabilities here in a second. that's your normal fetal heart rate. That's, we want to establish a baseline. What do we say that fetal tachycardia is? That's greater than what? And bradycardia? 110. So some of the causes of fetal tachycardia would be early hypoxia, maternal dehydration. What did we say? Dehydration is also a big trigger of
Braxton Hicks.
Braxton Hicks labor. Good. Amnionitis might be the first sign in patients. If they occur for babies that are showing fetal tachycardia, so inflammation of the amniotic fluid, the amniotic sac. Hyperthyroidism, maternal hyperthyroidism can cause fetal tachycardia. If the baby is anemic, they may have fetal tachycardia. Prolonged intrauterine infection. Sometimes you can see fetal tachycardia with excessive oxytocin. If it's good. Some of the causes of bradycardia, which is less than 110 beats per minute, is maternal hypotension. Prolonged umbilical cord compression, so baby heart rate is dropping. That's what caused Serena to have that emergency C-section, when she had the pulmonary embolisms we were talking about. Fetal arrhythmia, abruptio placental or placental abruption, uterine rupture. Fetal bradycardia is thought to be more concerning than fetal tachycardia. Seems to be worse outcome. So we talk about variability in our terminology. Fetal heart rate variability has been recognized as a predictor of fetal well-being. So if the fetal heart rate is variable, that's usually a good sign. That shows us that the baby's neurodevelopment is good, the fetal well-being is where we want it to be. So if you're not having a lot of fetal heart rate variability, that would be considered decreased variability. And some of those causes are CNS depressants, hypoxia and acidosis, immature neurological control, fetal anomalies, previous neurologic insult. So various different things can cause that. You just need to know that a decreased variability is not favorable. I expect you to know those specific causes. So let's look at accelerations. So you can't really see on here those numbers because they're blurred, but you can tell that your baseline is here. That's your baseline, and then you can see those accelerations. Okay. Baseline, then you see acceleration. And those are usually associated to uterine activity, and I forgot I'm recording, I can't move that much. So usually correlated with uterine activity or fetal movement. So you can see baby moved, and then there was an acceleration. There's some good examples of this online. Decelerations, we'll look at, can be caused by several different things. I left you a link for osmosis, does a really good little synopsis of fetal decelerations. Fetal deceleration is referred to a temporary but distinct decrease in the fetal heart rate. So instead of it going up, you're going to see it come down. And there are three types: early, late, and variable decelerations. The early signs are usually from head compression, which is common during the second stage. Late, oftentimes due to some type of uteroplacental insufficiency, and then variable is often due to umbilical cord compression. So we're going to look at each of those. The early decelerations are usually benign. You want to consider the stage of labor when you're seeing these. They begin near the onset of a uterine contraction, and their lowest point occurs at the same time of the peak of the contraction. So you'll see this is when the contraction began. The deceleration starts here, and it its lowest part matches with the peak of the contraction. The red line is where the contraction began. And the lowest point of the deceleration is at the same time of the highest peak of the contraction. That's your early deceleration. This is usually benign. It may be a sign of advanced dilation or that mom is getting ready to go into that second stage of labor. She is ready to push. Okay, so if you see this change, usually benign, possibly a sign that mom is dilated a face and ready to begin pushing. Late decelerations, we said this is often caused by uteroplacental insufficiency. So with late decelerations, their onset and return to baseline are gradual. So opposed to early decelerations, with the late deceleration often begins just after the contraction. So you'll see the contraction first, and then you'll see that dip in the heart rate. And then it goes back up well after the contraction is over. So late decelerations begin just after a contraction, with the lowest point occurring after the peak of the contraction, versus early, which happens at the same time. The low point and the contraction match. These decelerations are often associated with maternal and fetal conditions. We talked about uteroplacental insufficiency, but you may also see them in maternal hypotension from an epidural. The mom was given an epidural, and sometimes placental abruption. Is the placental abruption painful or painless?
Painful.
Painful, good. Vaginal bleeding, hard uterus. So for this, some of the interventions, we want to put mom on her left side. Remember that vena cava we were talking about? If the uterus is laying heavy on that, it's going to increase the amount of blood returning from the heart. So we want to turn mom on her side to relieve that. And once you relieve that, it allows more blood to pump through the body, and that will increase the flow of blood to the placenta. We want to consider supplemental oxygen. So oxygen on, and then it says oxytocin off. Oxytocin, contraction or relaxation? Contraction. So because the uterus, we want it to relax. We don't want it to contract here. Decreasing the frequency of uterine contractions allows more blood flow to get to the uterus. So we want to take oxytocin. She's getting oxytocin. You want to stop that flow. You want more blood flow to get to the uterus. Remember, oxytocin, which we'll talk about in postpartum hemorrhage, is going to help stop bleeding. So we want to get more blood flow to the uterus. We're going to increase IV fluids, and then we will consider tocolytics. If the decelerations are persistent, you might give a tocolytic like magnesium sulfate to help relax the uterus. Magnesium sulfate will help relax the uterus. When else do we use magnesium sulfate? Seizure prophylaxis. And what condition? Preeclampsia or eclampsia. Good. So our variable deceleration, we said, is often due to cord compression. So with this one, this is probably the most common type of fetal deceleration. Early, late, and variable. Variable decelerations are the most common type of fetal deceleration. They typically occur during the first and second stages of labor. They vary in shape, duration, and intensity. They often resemble letters. So they look like a U, a V, or a W. That one looks like a V to me, or kind of like the U. So you can see the contraction, you can see when it starts, you can see when it ends, and it's just kind of in the middle. But you can see that V shape. So remember, with variable decelerations, these look like letters, more like letters. U, V, W. And it usually doesn't have a constant relationship in terms of the contractions like you see with the late and the early. Interventions for this one, again, maternal repositioning. If the cord is compressed, we want to try and move mom around, see if we can kind of loosen that. Oxygen is on again. You need to perform a vaginal exam. Sometimes they have to actually go in and try to loosen, if they can feel the cord, or they may have to kind of move things around or quickly deliver the baby. Decreased amniotic fluid during pregnancy is associated with more frequent variable decelerations. The amniotic fluid plays a protective role in the umbilical cord. So if you have less of that, you may have issues with the umbilical cord. All right. Fetal monitor patterns. This is a resource. You can see a reassuring. Do we want reassuring or non-reassuring? Reassuring. We want a reactive reassuring pattern. We're going to talk about that in a second. This one shows tachycardia, elevated heart rate that's above the 160 beats per minute. Early deceleration, does that match the contraction or is it a little slow? It matches it. So you can see the contraction, you can see the dip. The deceleration, the contraction. So those match versus the late, here it's a little bit off. So either the contraction, it's already started, and it says peak after the contraction is ended. Those are late. So those are some examples, just to be familiar with. More examples that were just in the lecture: late deceleration with variability loss, variable deceleration with variable deceleration. That's way too deep for this lecture, but you can be familiar with it. And like I said, I'm going to send you a website that has a bunch of scripts, especially for those who are going to Capital Region for women's health. They do a lot more emergent medicine with their rotation, and you may need a lot more of these. See these changes, they do a lot more deliveries and things like that. So be familiar with that. This is the resource I gave you the last time. If you haven't looked at it, I still recommend you look at it. I think it's very helpful in understanding how to read a non-stress test. Again, we talked about reactive versus non-reactive. Reactive is defined as 2 or more accelerations of the fetal heart rate of more than or equal to 15 beats per minute, lasting more than or equal to 15 seconds over a 20-minute period of testing. We're going to talk about this in detail. The non-reactive don't meet that criteria. And if they don't, you need to wait and then test them again. And then we talked about another test you might do with fetal heart rate. Do you remember what it's called? Like a traction test, CST. All right, so here's an example that I pulled from the YouTube. I want you to watch the YouTube. Does a better job explaining it than I probably did. But the first box that you'll see helps us determine the interval between the timing interval. So that's showing you there's 10 seconds between each vertical line. The second box is showing us the heart rate, the baseline heart rate, and the reference. So between each vertical line is 10 beats, 10 seconds between verticals, 10 beats per horizontal. The baseline for this one is around 150. Around 150. That's the that can only like the acceleration peak there circled in green. The acceleration peak is around, let's see, if we're baseline is at 150, and this is 10, that's 160, 170, 180. So it's right in between, so it's around 165 beats per minute. So we take our baseline, which was 150, and we take that acceleration peak. 165 minus 150 gives us 15 beats per minute. So that acceleration is an acceleration of 15 beats per minute. And for the definition of a reactive, it has to be 15 seconds or more. So we look at the peak of the acceleration is between, well, 1, 2.5. So that's 10 seconds, 20 seconds, 5 seconds. So a duration of 25 seconds. That's how you measure the fetal heart rate change. So let's look at this, the reactive, the definition, and this shows an acceleration of 15 beats per minute, lasting 25 seconds. So is that reactive or non-reactive?
Yeah.
It's reactive. That's what you want. There is a way to memorize the deceleration. Dill chop mine is a mnemonic that they use. For this, the variable is deceleration, remember. Variable, E is for early, A is for acceleration, late is for deceleration. So you want to remember those are the different types. The causes, forward compression, head compression, okay. Placental insufficiency, when you watch this osmosis, they'll explain what these mean, and the management. So the management for cord compression might be maternal repositioning. The management for head compression would be to identify labor progress. The acceleration, no interventions, because we want acceleration, we want fetal movement, and we want heart rate to move with it. That tells us the babies can tolerate the stress of the contractions. Late deceleration might be due to uteroplacental insufficiency, and the E or the management for that would be to execute interventions, but I would recommend you look at the osmosis for that. Interpreting fetal monitoring. So we need to know the normal baseline. You need to be able to pull out that normal baseline. Check for accelerations with fetal movement. Sometimes they will present with short-term variability. There are 3 to 5 cycles of long-term variability per minute. There may be early decelerations present. These are all okay. These are reassuring on a fetal trace. What we don't want to see, this is what you need to remember, what you don't want to see are severe variable B cells. But the fetal heart rate drops 70 for more than 30 to 45 seconds. Any type of late deceleration of any magnitude is not favorable. Absent variability. So what I didn't really talk about with the variabilities is 3 types: marked, moderate, and absent. That's too advanced for this class, but if there's no variability, whatsoever, that is not good. Remember, fetal heart rate variability tells us about the neural development and the well-being of the baby. So you want some variety there. When it's none at all, this is not good. Prolonged deceleration, anything lasting over a minute to 60 seconds to 90 seconds. And then severe bradycardia, fetal heart rate less than or equal to 70. Non-reactive stress tests don't necessarily mean there's a problem for every patient, but it does tell you that you probably need to do more testing. False positives, you can have false positives on the fetal tracing, like in terms of a non-reassuring, if mom smokes and if she ingests certain drugs. So what do we do for this? Maternal repositioning, we talked about that. Sleeping on the left side is ideal. Being on the left side, positioning yourself, allowing that blood flow from the inferior vena cava. You want to monitor mom for hypotension. Give IV fluids as needed, oxygen is needed. Considering discontinuing oxytocin. Place internal monitors as needed. We only place internal monitors if the membrane has ruptured or it hasn't not. Only if it's ruptured, right? Fetal tracing can provide the client and family with explanations of what's going on. And you want to be able to give this to your patient. And then administering tocolytics as ordered. Said tocolytic relax or contracted uterus. And what's an example of one? Mag sulfate. Good job. All right. At the labor video, there are, this is an animated video. We'll try to get to that video in a second. If not, watch it on your own. Like I said, there's a natural live birth on there. It's a little bit graphic. You might not want to watch it in Starbucks. But there you can watch the video if you need to, especially if you've never seen a birth before. I don't find that a lot of VAs get to deliver babies. When I had my rotation in Swaziland, Africa, where I was able to deliver a lot of midwife, and then of course physicians deliver here, but you may have the opportunity. Definitely you'll see them, but I don't know how much hands-on you'll have. But very interesting, very amazing things that our bodies can do. So definitely take a look at that. Postpartum begins with the birth. So baby is out, and this begins our postpartum period. It ends at approximately 6 weeks. Like we said, some doctors call this the fourth trimester. Reproductive organs and the maternal physiology begin to return to their pre-pregnancy state. The menses may not return during this stage. So the first 6 weeks, mom might still get a break and not have to return to a menstrual cycle just yet. So we talked a little bit about the involution of the uterus. Basically, immediately after the delivery of the placenta, the uterus will start to return to its non-pregnant size. So it's gonna involute into a smaller organ. It will go back to its pre-pregnancy condition anatomically and functionally. We often call this the fourth trimester because there are something called after pains that some women experience, which are like mini contractions, kind of like menstrual cramps. And this is all part of the uterus going back to its normal pre-pregnancy size. The fundal height will decrease as the mom breastfeeds. That helps the uterus to go back to its pre-pregnancy stage. The placenta will heal by exfoliation, which we're going to look at on the next slide. There is a discharge called lochia, which you will see on exam after birth. It's a mixture of blood, mucus, and uterine tissues. We classify it by its appearance and content. So you'll see pictures there on the side where the first stage is very dark, bright red blood. This lasts a few days. It flows like a heavy period. Sometimes you'll have clots. Sometimes you'll have cramping, usually mild. And then as time goes forward, it goes from dark to bright red to pinkish brown. It's less bloody and more watery. This can last several days. The flow is moderate. There's usually no clots, or there's less clotting if you had clots prior to. And then the last stage of the lochia is white to yellow discharge. Little to no blood. This lasts either 12 days to about 6 weeks. Usually no clots. I remember seeing a lochia in my OB rotation in the United States, not the one in Swaziland. But I don't remember the smell. And some people describe it as a stale, musty odor. It's kind of like a earthy type of smell. If it's foul smelling, like different, that is not a good sign. That's endometritis or inflammation or infection of the endometrium, the lining of the uterus. Okay, so it's different. So there may be a little bit of an odor with it that would be probably normal if it's very foul smelling, or you're not for sure. Definitely check with your preceptor. You want to document the type and the amount. Is it moderate? Is it light? Is it yellow, white, pink, brown, dark red, bright? Breastfeeding. The CDC's Division of Nutrition, Physical Activity, and Obesity are committed to increasing breastfeeding rates throughout the U.S. There are two different recommendations. The American Academy of Pediatrics recommends exclusive breastfeeding for the first 6 months and then continued breastfeeding for at least 12 months with complementary food, and thereafter for as long as the mother and baby desire. Always see that in the news. Oh, she's still breastfeeding. He's 3 years old, or different things like that. The World Health Organization and UNICEF recommend early initiation of breastfeeding within 1 hour of birth and continued exclusive breastfeeding for the first 6 months of life, and breastfeeding for up to 2 years or beyond with nutritionally adequate solid food. A lot of moms say when the baby comes and gets it out itself, it's time to, that you can kind of determine, moms can determine on their own when they're ready to stop. Sometimes they do it for soothing as well, and it's not even necessarily nutrition, that they just want to be soothed. There are changes of the breast. So there's a progression from the breast going from soft, filling to full as the milk comes in. There is something called colostrum, which is a very watery type of production that happens the first few days after birth. This is full of immunoglobulins, antimicrobial properties, a lot of good stuff in that. And then it will mature to milk. Increased blood flow and mature milk lead to engorgement. So women will say, I'm engorged, but the breasts feel completely full and solid, and they have to pump or feed the baby. As the baby suckles, it will stimulate prolactin. We talked about prolactin, lactin, and lactation, as well as stimulation of oxytocin. Oxytocin promotes prolactin release and helps in milk production. We talked about oxytocin having a role in lactation, but not as much as prolactin, but they do work together in breastfeeding. Breastfeeding is all about supply and demand. The more frequently the baby breastfeeds, the more milk mom's gonna make. For most cases, there are some patients that have struggles trying to get milk. Some of the benefits of breastfeeding. It protects the babies from infections and illnesses, including diarrhea, ear infections, and pneumonia. Breastfed babies are less likely to develop asthma. Mothers who breastfeed have a decreased risk of breast and ovarian cancers. And it's a money saver. Families who follow optimal breastfeeding practices can save $1,200 to $1,500 on formula in the first year alone. Some women struggle with breastfeeding and have to have lactation nurses help them. So, I do find like a lot of, do you breastfeed or do you not? Just a lot of controversial things with that. Do what your patients want. Definitely recommend, but don't force anything if they don't. And then this is just a do you know section. We're not gonna do these. Are you familiar with the OB vocabulary? Fetal life, fetal position, fetal presentation, station, engagement. Do you know the 5 Ps? What are the 5 Ps? Let's try to do those. What's the first one? What's the part? Passageway. Passageway. The uterus, the vaginal canal, the cervix. What is the second P? Who wants to take the ride? The passenger, the baby. The baby. What's another P? Power, supermom, uterine contractions, the contractions, the strength of the contractions, those types of things. Next P.
Like,
We do know psych, psychology, mom ancient, which you should read. No,
position.
it's something about how the baby is. It'll make you dizzy. Dizzy, dizzy, dizzy. Did I pass it?
No, I think I'm still not there. Oh, there it was. Position.
Position. Passageway, passenger, position, power, psychology. Right, so those are some things you need to know. I want you to definitely take a look at the video for the non-stress test, we get familiar with the fetal heart rates. Fetal heart monitoring options are on there. Know what your baseline is, what is tachycardia, what is bradycardia. Then, next question, in your resources, I did put a few other examples, but I'm going to put in Blackboard the website so that you can have the practice, you can practice with those. Okay. When we come back, we are going to do, we're gonna do labor complications. So on Thursday, it's gonna be, labor complications.